For those of you who don't know, gout is caused by a crystal called uric acid, and my wife said the title was too subtle, and I ought to have some disclaimer there. So that's I got Acute, and that's where the title came from. Okay, so we're going to talk about gout tonight, and it's really one of the favorite things I take care of. It's a really interesting disease, and you know, over time, you know, people come in really hurting with a gout flare, and then we get them under control, and they're happy, and I'm happy, and then I fire myself, and they go back to their family doctor, and life goes on. So it's life's really good. I enjoy that. There we go. The other up. So gout is a disease in response, again, as I said, to the presence of crystals. The formal name of the crystal is called monosodium urate. We just call it uric acid crystals. And the thing that happens is uric acid is a byproduct of protein degradation. As we eat proteins, meats, or take in substances that contain protein substrates, our body breaks down, uses what it can use, and what it can't use, it converts to uric acid and then asks the kidneys to get rid of it. And what happens is when uric acid builds up, once it saturates the bloodstream, then it kind of pours off into the tissues, the joints, the soft tissues, and that's when it causes deposits and later causes gout flares. And this is a lithograph from 1799 showing somebody, the little devil's chewing on the guy's big toe. So the way this all works is that hyperuricemia, or elevated uric acid levels in the blood, then lead to monosodium urate, MSU, crystal deposition. And what happens is it deposits in the soft tissues, deposits in the joints, and then over time what happens is it causes a gout flare. Now what you'll see here, these are classic gout crystals, and they look like little javelin spears. And when they form large collections, they form tophi, or little nodules. You see these little yellow kind of nodules right there. And so hyperuricemia, for the vast majority of people, probably 90% of people, it's not that we make too much of it, it's that we just don't get, our kidneys just don't get rid of it fast enough. And so that's it right there, is impaired renal excretion. Our kidneys just don't flush it out enough. Now there are some inborn errors of metabolism where people are genetically predisposed to just creating a lot of uric acid, and so they actually do make an overproduction, as we see here. Or what we'll see is what you've heard in the past. It was the disease of kings, you know, because of all the wine and the meats and things like that they were predisposed to having what we know now as decreased renal function, which then led to gout. So there are certain non-modifiable risk factors, meaning risk factors that we have no control over. Men are predominant gender that gets gout. Women during childbearing years, premenopausal, the estrogen in their body helps promote uric acid flushing from the kidneys. So it actually protects women from uric acid during childbearing years and during premenopausal years. But once a woman goes through menopause and loses that estrogen drive, then what happens is their uric acid levels just go right up to that of men. But with most situations, you have to have hyperuricemia, or elevated uric acid levels, for a number of years before you have your first gout manifestation. So that's why it's still men that have more gout than women. So advanced age, I mean, the longer you live, then the longer you have to actually get gout. And then ethnicity. Certainly blacks, for example, tend to have more difficulty, and other ethnic minorities tend to have more difficulty with gout than Caucasians. Some of that is certainly genetic, we believe, but some of it also may be that blacks or other minorities are not treated as aggressively for gout in other countries as they might be. So then we look at the modifiable risk factors. Obviously, being overweight is an issue. Too much alcohol. As sophisticated as the kidney is, it has a very simple acid transport system. So what happens is when it's confronted with an acid, like uric acid, okay, and it's confronted with another acid like alcohol acid, which is converted to ethanolic acid, it looks at both of them and says, well, which one can I get rid of easiest? And the alcohol acid wins out. And so what happens is while the kidneys are flushing the alcohol acid, the uric acid builds up waiting its turn. And if it builds up high enough, it can actually trigger a gout flare. So that's why alcohol is on the list there. Now what's interesting is that beer contains guanosine, which is a protein substrate. And so actually of all the alcohol beverages, beer is actually the worst. Okay? So you can get by with drinking a little red wine or having even a glass of hard liquor, but it's the beer that gets most people. Okay. Thiazide or loop diuretics, they can cause hyperuricemia. Oftentimes, though, it doesn't lead to gout, but it certainly can exacerbate it, because what happens is the water pills, if you will, help promote reabsorption of the uric acid. It flushes the urine out, decreases their water content in the body, so it dehydrates the patient. Then you reabsorb some of the uric acid, so now you have even more uric acid and a smaller amount of fluid. So that can lead to that. And then certainly there are other medicines. Diets, high in diets, certainly organ meats, gizzards, liver, some shellfish is another one that can cause it. So usually my hunters, I just advise them, not that they can't eat it, they just need to do it in moderation. And hypertension and some sugary drinks and obviously other medical conditions. So again, hyperuricemia is very important for the pathogenesis of gouty flares, but it's not the whole story. There are some people, and matter of fact, the majority of people that have elevated levels of uric acid in the system never develop gout. And so people say, well, why is that? Well, there may be just individual differences in crystal formation or their particular body's inflammatory response to those crystals. And then higher levels of serum uric acid increases the risk for developing gout, but not necessarily relates to the severity of the gout flare. Here's another lithograph from, I think it was 1885, and so you see the man screaming there in pain as he's got his feet wrapped up. And you can actually look back, they actually made gout stools. They looked like little curve-shaped ottomans that people would prop their feet on so that it wouldn't touch the floor because it'd be so hard. So the prevalence, there are about 3 to 8 million individuals in the U.S. that get gout, and but it's worldwide, and it appears to be increasing. Little known piece of trivia fact: the only other mammal besides humans that get gout is Dalmatians. So you can impress your friends, because they lack an enzyme to break down uric acid, so they make uric acid. Okay, so diagnostic and therapeutic advances have certainly influenced the course of gout. I mean, just in the last 50 or 60 years, we actually have polarized microscopy where we can actually take fluid out of the joint, look at it under the microscope, and actually see gout crystals for the first time. So that, once we were able to do that, then the documentation that these crystals actually cause gout led to further investigation and the treatment that we now have today. Okay. But this is probably the biggest thing I fight in treatment is people just think, I'm going to get over this, and if I don't take it, then it's not going to come back. And of course they're wrong, and it does come back. And so getting people to kind of get on board the train and say, okay, I have this problem. It is a lifelong management, but it can be managed, and people do very well with it. But you have to take your medicine, And one of the things, the biggest thing I do to combat that is I just tell people, I just keep educating them. And then after a while, I just say, okay, I've told you all I know. Either you accept it or you don't, and you have the next move. So classification. There are certainly people that get chronic levels of uric acid in the bloodstream. Again, the primary are those that there's no other associated cause, meaning they don't have any other associated medical illness, or they're not exposed to any other medicines that led to it. They just have elevated uric acid levels in gout just because they do. Okay. And then there are those people that make too much of it, as we talked about before. It can be a genetic problem, or perhaps they have decreased renal clearance because they have kidney failure, and so that predisposes them to gout. So we have 3 clinical syndromes, or if you will, 3 stages. Now everybody's aware of the acute gouty stage. The one that people don't think about is what they call the intercritical gout attack, or gout phase, I should say. And basically intercritical just means they're in between flares, okay? You've had a flare before, the next one hasn't come, and you're in that sweet spot where you're not having any symptoms, you think life is good, and then boom, the next one hits. Now what happens over time is that if you don't treat these 2 phases, then people get chronic recurrent tophaceous gout. So what happens is they get into a chronic state of inflammatory response where they just have chronic gout symptoms. What often happens with the acute flares is they get a flare up, they get better, they get a flare up, they get better, and what happens over time is that the intercritical periods, or the intervening periods of normalcy, if you will, become shorter and shorter and shorter, and the flares become longer and longer and longer until it just becomes just one chronic level of discomfort or flare. Okay? And so that's the chronic recurrent and tophaceous gout. That's why these are the people that we really want to prevent. You know, I want to stop it here so that we don't get down to here. Okay. So predisposing factors, trauma, surgery may lead to stress, dehydration, which then concentrates the uric acid, which then stresses the kidneys, then leads to gout flare. So it's just kind of a cascade of symptoms, and that's what we see here. Dehydration, sometimes excessive meats, we talked about that before, certain medicines that raise or lower the serum uric acid level, alcohol consumption, that type of thing. Another interesting little tidbit, a common time for a gout flare in the hospital is 3 days post-operative. You know, so they've been in the stress of surgery, they might have gotten dehydrated, and the 3rd hospital day they flare. Or the 3rd day after a heart attack, they'll flare. So we see that. Okay. This is also another interesting, people often ask me, well, why does a gout flare typically occur in the big toe? And one of the reasons may be, well, the big toe is farthest from the heart. It's actually the coolest part of the body, and that's where crystals, or the fluid, actually crystallizes in the colder parts of the body. Okay. So a typical attack, some hallmark features, intense onset, intense pain, swelling, redness, warmth, often occurs in the middle of the night. People will wake up with it 3 or 4 o'clock in the morning and just think, I broke my toe, or something just horrible had happened. Usually reaches its maximal severity within 12 to 24 hours. 80% of the attacks involve a single joint. That's why in the classic podagra attack, it's the joint of the big toe, as you hear. Signs of inflammation can extend beyond the scope of the joint, so sometimes the whole foot will turn red, and at times it can actually look like an infection, cellulitis, and so it can often confuse a lot of people. And there's such intensity, you know, people will describe sensations that even when the air conditioner kicks in, the wind blowing across the room from the air conditioner kicking in will make their gout pain worse. Just the breeze, okay? Or a sheet, just a light sheet hanging over their foot will be enough to create a lot of discomfort. So it's intensely painful. Now what you'll see in the other thing, the people, it can occur in basically any other joint. We think about the big toe, but it can be in the midfoot or the wrist or the knee or the shoulder. You just have to be aware of that and look for it, especially in those people that don't present with the classical big toe. They come in with their first attack and it's in the ankle or it's in the knee, and you take fluid off and you see the gout crystals and you make your diagnosis. Sometimes as the attack is resolving with the redness and the warmth and the swelling, the skin overlying the inflamed joint will actually peel like a sunburn. We call it desquamation, okay? And I think I have a picture in the slide set I'll show you. Now, the other thing is that, especially with the early attacks, even untreated, these attacks will resolve within a few days to several weeks spontaneously. Of course, you've lived with the pain and all this over those course of time. Okay, so here's a classic podagra, the big toe. It's really red, and I told you that it kind of spreads outside the confines of the joint, and you see, so you can see how somebody might mistake this as cellulitis when it's just intense inflammation of the joint. What you can see on lab work, and it is variable, you can see an elevation in their white blood cell count because of the inflammation. You'll see elevation in their SED rate and CRP, which are acute inflammatory markers. This measures chronic inflammation. This measures more acute inflammation. What's really interesting during a gout attack, we talked about these people having elevated serum uric acid levels. It is not uncommon that actually during an active attack, the uric acid levels in the bloodstream may actually fall to normal. Okay, and so, is that a result of the attack or is that the cause of the attack? Because sometimes what happens is if you have an elevated serum uric acid level, it's like two tanks. You fill up the bloodstream and then you fill up the tissue. Okay, and then what happens is they have some event, dehydration, illness, medicine, whatever, that all of a sudden drops their blood level of uric acid. And so what happens, the body hates disequilibrium, and so it starts to mobilize the tissue-bound uric acid and puts it back into the bloodstream so that it evens out. But it's that transition and mobilization of the uric acid crystals into the bloodstream that triggers the attack. But what happens is the initial part of that attack was the fact that the serum uric acid level actually fell to normal. So the most accurate time to get a baseline assessment of the serum uric acid level is at least 2 weeks after the resolution of the gout flare. Okay. So the diagnosis, as soon as you really think that it's gout, you really should try to get documentation of uric acid crystals, because there's no other way to absolutely prove it's gout unless you have documentation. But sometimes that's not possible. It's in a joint that's not amenable to swelling. There's not enough swelling, but there's intensity of the gout flare that makes you think it's gout. Or as my father would so eloquently say, if it walks like a duck and it looks like a duck, it's probably a duck, okay? And so that's where you get to this provisional is if they have the right clinical history, if they have the right physical exam, if you find other laboratory tests that make you think that that's true, or sometimes even imaging studies, that gives you enough information to say that, yes, this is in fact a gout attack. Okay. And so when we do take fluid off the joint and we look at it under the microscope, this is what we refer to as a polarizing microscope. And this is what the uric acid crystals look like. You can't always go by morphology, or what I mean by that, by how they actually look. You see the uric acid, they look like a javelin spear, okay? And this is pseudogout over here. It actually looks like a blunted rod. It's like somebody had taken the javelin spear and knocked the points off. So it looks more like a rhomboid looking cylinder, okay? But when you put them under a polarizing microscope, which adjusts the wavelength of the light going through there into one pattern, they all of a sudden reflect different colors, okay? This yellow or this blue. And so if this is the wavelength of the microscope, this black arrow, okay, when you look at gout crystals, okay, the yellow gout crystal here is in the same axis. It's parallel to the axis here, and so it's yellow. Now, if you turn that uric acid crystal 90 degrees and put it perpendicular to the axis, then it looks blue. Whereas the flip side is true for pseudogout, which is caused by a gout calcium crystal. Okay, we talk about gout being uric acid. Pseudogout or false gout is caused by a calcium crystal, and it refracts completely opposite. So when it's parallel to the axis, it's blue, whereas uric acid or gout was yellow. This one, the pseudogout, is blue. And when it's perpendicular, it's yellow. And that's why you see in these two examples, when it's parallel to the axis here, it's yellow, and when it's perpendicular to the axis here, it's yellow, but it's blue there, just like that. So this is pseudo-gout, and that is gout. But again, the purpose of doing the assessment is because sometimes you think it's gout, okay? You aspirate their joint, and what you actually get is pseudo-gout or calcium crystals. And that's important because although you may treat the acute attack the same, okay, allopurinol does not treat one of the preventions of gout does not treat pseudo-gout. So you don't want to put people on a medicine that's not going to help them. Okay. So the criteria for the clinical diagnosis, I kind of went through that. Remember the classic history we talked, sudden onset, maximum inflammation within 24 hours, usually the big toe. There's a lesion likely to be a tophus or a collection of gout crystals that you can actually aspirate. They have an elevated serum uric acid level, or sometimes they'll have radiographic findings. Now, obviously, if this is their first or second attack, you're probably not going to see any X-ray findings, but if they've had it longer, you may. Now, if gout isn't treated or isn't properly treated, what happens is you lead to these tophaceous deposits. And if you were to break these sacs open, just like you see here, it just pours out this white chalky stuff. And it looks white and chalky. It feels that way, it looks that way, okay? And, and again, either people have just completely ignored it, okay? Or they knew they had gout, they just decided they didn't want to take medicine for it, and again, that's their choice, but then that's what they're setting themselves up for. But again, I try to combat that by really trying to teach people about, okay, what is this, and why are we treating it, and what's the purpose? Some people, though, are inadequately treated. I mean, there's been some studies to suggest that people with defined gout have not been treated as aggressively as they should. We now know that the target goal for treating uric acid can be measured in the bloodstream, and we want to keep the serum uric acid level below 6.0 milligrams per deciliter. If we keep it below 6, that's the threshold upon which the bloodstream can actually hold uric acid, okay? It's kind of like, I'm from the South, so I think about putting sugar in tea, okay? I put sugar in tea and I stir it up and it dissolves, okay? But if I keep dumping sugar in there, eventually the fluid becomes saturated and the sugar just falls to the bottom, okay? And so the idea of having it under 6 is that physiologically we can hold 6.8 in our bloodstream. So if we can keep it under 6, that's kind of a sweet spot for treating gout. Now, if they have tophi like this, our target goal is 5 milligrams per deciliter, okay? So anyway, then we look at the intercritical and the recurrent gouty attacks. Again, the intercritical is the interval period of normalcy between flares. Again, it's variable in duration, but the longer you have it, those intervals become shorter and shorter and shorter. And then people get these recurrent gouty arthritis where, what happens is the attacks become longer and longer in duration, and they just can't seem to shake it. And when that happens, it certainly can be disabling, and I have seen people with gout flares actually have fever. And this is the hard one, is when they actually develop a polyarticular flare, meaning you don't have one joint flaring, you have multiple joints flaring at the same time. In which case, then they're really in a world of hurt, because then it's both feet, or it's both feet and an elbow, or it's really very difficult. Okay. Well, tophi are these collections of gout crystals that you can actually see in the tissues. And sometimes when I make a diagnosis of gout, I'll actually prick one of these things with a little needle and just kind of unroof it, and just squeeze out a little bit of the uric acid crystals and put it on a microscope and look at it. The interesting thing is that, let me get back here. The interesting thing about this is that tophi really aren't painful. So you can manipulate them, you can't touch them, you can do anything with them, and it's not like a gout flare. I mean, the tophi are just deposits of crystals. And so when I do poke it with a needle or whatever like that, usually it's not painful, but it makes the diagnosis. Okay. So acute polyarticular gout, I've seen a few of these in my career, and I really don't like them because people are just, they're miserable. I don't think, at least in my population, I haven't seen 20% of patients or have that, but certainly I have seen a few. Again, the key there is you're more likely to have it in later flares, or particularly in untreated gout, particularly those with multiple recurrences. They have shorter absent symptom-free intervals, and they're much more likely to have actual tophaceous deposits. Okay. And so here you can see the skin is actually ruptured, okay? And that's actually a tophus, or a collection of uric acid crystals right under the skin. And when you pull it out and look at it on the microscope, before I showed you a bunch of individual crystals, when you pull crystals out of this, you just see a nest of yellow and blue, and it just, you look at it, the microscope screen just kind of explodes with color. It's, for as mean as it really is pretty to look at that. So they're collections of solid urate crystals in the tissue. Again, they're not typically painful or tender, the crystals themselves in there, but the swelling may extend beyond the joint. And you can kind of see here, see where his skin is kind of peeled right here? That's from the flare where, it's almost like a sunburn. The skin is just sloughed off after the flare. Okay. And then, but the other thing about these tophi is that when people get to this condition, they can actually get bony erosions, and that's what you'll see here. You see these soft tissue are the gout, and the inflammatory process has actually eaten away the bone. And you can't see it here, and this is from probably where you're sitting, but these are erosions into the bone where the bone's actually been eaten away. And what happens, they have a very distinct look. They kind of burrow into the bone. So when you're looking at one of these erosions in the bone, the edge of the bone kind of peeks over like a crown, or what we call an overhanging edge. And so the gout will eat into the bone like that, but leave these little sharp edges, or overhanging edges that we see here and here that give us a clue to the diagnosis on a plain X-ray. And this is the other thing. Sometimes people, if they don't take a careful enough history, they sometimes may confuse these erosions for rheumatoid erosions, but this is classically gouty arthritis. And so the devil is putting a coal on this poor guy's foot. So, but anyway, the treatment of gout is, the goal is prompt and safe termination of the flare and to prevent disability. Okay, and so ideally we want to treat the gout as soon as possible. One of my instructions to patients is when they're having gout flares is that you don't want to treat every twinge of pain as a gout flare, but people will go, well, how will I know? And usually somebody who's had at least one flare will know. I say, when that little voice in the back of your head says, oh my goodness, here it comes, that's when you treat it. Yeah. You don't wait for things to explode. You don't wait for 2 or 3 days down the road. You as soon as you're convinced that flare is coming on, you treat it. Okay. And one of the other common mistakes that people sometimes make is that you want to treat the flare for a minimum of 2 to 3 days after the resolution of the symptoms. Because what happens is sometimes they take the medicine, they go, oh, the flare is over, and they stop the medicine that day, and then what happens is the flare rebounds, and it's worse the next time. So I usually tell people you want to treat it for at least 2 to 3 days after the last symptom, just to be sure the flare is gone. And most patients, especially early flares, usually within about 5 or 7 days, the flare resolves. My population is a little bit different because usually by the time somebody actually gets to me, they've had more than one flare, and their family doctor's been trying to help them through it, and it's just all of a sudden by the time they get to me, their flares are lasting weeks at a time, and so that makes it a little bit more difficult. Okay. And then the other thing is that I never start final therapy during a gout flare. There's been one anecdotal paper suggesting that it doesn't make a difference, that you can do it, but conventional wisdom is such that you never treat a gout flare permanently during the active flare. Your goal is calm the flare down first, get them into that intercritical period when everything's quiet, and then start definitive therapy. Because the problem is, if I put you on a medicine to lower your uric acid level, okay, and you're having an active gout flare, then I'm just going to magnify that disequilibrium. I'm going to drive your uric acid level even lower. I'm going to mobilize more and more soft tissue uric acid. I'm going to make your flare worse, okay? And so that's why I put this in there. It's kind of like striking a match. You just don't want to do that. Okay. So initial treatment, and again, this depends upon the patient. They may have certain other health issues that I need to take into account as far as, so it may affect what I choose as the initial therapy to control their gout flare. I may have some history based upon what the patient tells me of what worked for them in the past. Or sometimes I may say, gee, I want you to take medication A, and they go, I'm not taking that medicine. So okay, medicine B, and we do that. So, and also sometimes if we have a history of proven gout before, sometimes actually injecting the joint with a local steroid injection can be helpful because it really puts the medicine right where you want it. So for acute gout flares, the three things that we use most effectively for treating acute gout flares are the anti-inflammatory medications like naproxen, over-the-counter would be Aleve, or indomethacin is the one historically that's been used the most. Indomethacin is a tremendously great drug for gout. Nobody really knows why, but it's a drug made for gout, and it's a great drug in that regard. Interestingly, one of the problems with indomethacin, though, is that a number of people that take indomethacin really get these funny headaches. Usually you take an anti-inflammatory pain reliever to get rid of your headache, but indomethacin in some people can actually cause headaches, and so that's or the other thing, I usually see this in white-collar people, accountants, number crunchers, people that do real detailed-oriented jobs. They go, it doesn't make me feel funny, or I'm just not clicking, like 6 of the 8 cylinders are working. I'm getting the job done, but it's tough, So that's another interesting thing about indomethacin. It doesn't happen with everybody that way, but it does happen enough that I usually tell people like that to be aware of that. Colchicine can be low-dose colchicine can be a really good therapy. It has its own particular drawbacks, and I'll talk to you about that in a second. And then corticosteroid therapy, either by injection or orally, can be very effective. It's the best anti-inflammatory we have. And so, again, for a lot of the people who have tried other things and get to me and that are still having trouble, it's really a common thing that we use that makes a big difference for people. Okay. First-line therapy are the non-steroidal agents we talked about before. It's most effective, again, if it's used early. Don't give gout 3-day head start and then say, oh, I think I'll treat this now. Treat it sooner. For people that are generally otherwise healthy and that have good kidney function, usually adverse reactions with the anti-inflammatories are uncommon. Now, if they do have other health issues or their kidney function is not the best, that may not be the choice for them. If they need to be on longer, then we need to do also something to help protect the stomach. But again, if you're using this, you want to discontinue this about 2 to 3 days after the last clinical sign has resolved. Colchicine, great drug, been around, used by the Egyptians probably over 1,500 years ago. One of the downsides to colchicine right now is just sheer cost. It's ridiculously expensive for absolutely no reason, and I may tell you about the horror story of that later on. But it's a great drug. It's very effective. The way it works is that when white blood cells are called into this area of inflammation, they release enzymes to dissolve the crystals, but those enzymes are very inflammatory themselves. So it's kind of like adding, misery to the situation. What colchicine does is it stabilizes those white cells so it doesn't release all those enzymes so aggressively. And so you're able to get over the flare without creating actually more inflammation. Okay. We have to be careful. Colchicine in people that have low kidney function, you have to be careful how much you use because people can get a lot of side effects to it. They talk about common adverse effects of colchicine toxicity, and that's an important thing to say here. One of the symptoms of having too much colchicine in your system is you get abdominal cramping or diarrhea. That is not an allergic reaction, that's a toxicity. I mean, everybody gets that if they get too much colchicine, okay? So that's the way, 40 years ago, that's the way they treated gout. They say, take one of these little pills every hour until you can't leave the bathroom. Then you're, okay, but of course at that point, then you're completely miserable for the fact that you're living in the bathroom and you forget all about your gout. So we don't do it that way anymore, okay? Okay. So the Song of the Gout, this is back in the early 1800s. Yeah, somebody actually wrote a song about it. So for people that have reasons why they can't use the anti-inflammatory medications or colchicine, glucocorticoid therapy, this is basically prednisone or injections can be used. And it can really be very helpful. If people have polyarticular gout, meaning they have more than one joint affected, this is really a great drug because it hits all the joints at one time. Okay. It's also, there are some people that for whatever reason, maybe in the hospital and they can't take pills orally. It's something you can give through the vein. So steroids are very helpful then. But again, steroids are the most powerful anti-inflammatory that we have, and it's very effective in controlling gout. Okay, so prevention of recurrent gout. So this is key. Okay, you're over the flare now. We're trying to say, okay, how do we prevent future attacks? And so again, the goal is, what is the safest way that we can do this, and how do we give prophylaxis for prevention of recurrent gout in the future? Certainly some lifestyle modification is important. Obviously managing your weight. A lot of education about, okay, if you're going out with the boys for a steak on Friday night, have a 6-ounce steak. Don't have a 16-ounce steak, or if you're going to have a beer, have 2 beers. Don't have 6. I don't pretend to get people to be teetotalers. I just want them to just kind of, let's kind of get it down to a level that we can deal with. Because the problem is, if they don't, we're treating on this side and we're creating the problem on that side, and so I'm just trying to find a happy medium. And usually most people understand that, and they do well with that. Obviously, they need to have their blood pressure under control and be sure that their kidney function is as best it can be. And then we start looking for drugs to actually lower the serum uric acid level. Again, for most of these people that have elevated serum uric acid levels, most oftentimes 7, 8, 9, 10, okay? And again, the magic number is 6.8 physiologically, and we want to get them down below 6, okay? So we need to do something to actually lower their total body uric acid level by managing their medicines in that regard. And then oftentimes what I'll do is if somebody's had a lot of gout attacks, while I'm starting a medicine to control their gout long term, I may have to put them on a little bit of a medicine to help kind of prevent flares while we go along. Because as soon as we start, say for example, allopurinol, which is the most common urate-lowering medicine because it's cheap and it works. For the first 6 months of allopurinol therapy, your risk for having another gout attack is actually higher. Okay, and then after 6 months, your risk for having gout attacks continue to decline thereafter. So oftentimes I'll use a little prophylactic medicine, maybe a low-dose non-steroidal or a little bit of colchicine, or some situations even a low dose of steroid to kind of help control their symptoms until I can get their uric acid down and stable, and then I get rid of everything else, and hopefully by the end of 6 months to a year, they're on allopurinol, they're doing great, and I fire myself. So that's the goal. Okay. So prevention of recurrent gout. I love this. I stole this concept from my partner who told me, and truth in advertising. He may have stole it from somebody else, but I love the analogy so well that I used it. Gout is like a bundle of matches, okay? And when you're having a gout flare, I mean, the whole thing's going, you know? And so the purpose of treating the acute flare is to get the matches calmed down. So basically, it's like throwing water on the matches. You just you know, you're not trying to get rid of the matches. You're just trying to calm the flare. Okay. And so now the flare's calm. So you got your bundle of matches. Okay. And what allopurinol does is it takes one match out at a time. Okay. And eventually, over time, the bundle gets smaller and smaller and smaller until the bundle's gone. Okay. Now the problem is if you're too aggressive in lowering the uric acid level, if I start taking out 5 or 6 or 7 at a time, then what happens is in that extraction, I may actually set off the whole thing. So you want to be methodical about how you do that. Okay. And that's where the prophylaxis comes in. You know, I'm using allopurinol to take the match out one at a time, whereas I'm also giving them a medicine to keep the matches wet. Okay. So that's how you can kind of think about that. And we've talked about risk reduction. I'm not going to go through that anymore. But I love the matches, so I had to show you. It's hard to quantify that. We just know that people that are heavier, that you're at increased likelihood, and that may have more to do with, you know, how fast your kidneys filter and the strain that's on the body in that regard. We know that it does. It's hard to say what percentage that does. I think as far as I'm concerned, I'm more interested in knowing about, you know, what's your kidney function, what's your alcohol intake, you know, are you know, how much protein are you shoving in? Those are the kinds of things. Usually for a lot of my patients, alcohol is probably the biggest thing that I worry about. I pick my fights where I can. And if you can lose 30 pounds, then, you know, go for it, you know, but good question. So I like this slide too because it shows the gout flare kind of slowly resolving. And that's the goal with uric acid crystals is we want to prevent frequent disabling attacks, prevent bone damage, remove the tophaceous deposits. You know, gout is also associated with increased risk for renal insufficiency, so we want to be sure we try to protect the kidneys as best we can. Sometimes people actually make so much uric acid that it actually stimulates kidney stones as they're flushing out. Because what happens is the uric acid gets in the tubules of the kidney starts to wrap those uric acid crystals in calcium, and all of a sudden you've got a kidney stone. Okay. Okay. So, and here's the example. You know, when we're trying to lower your uric acid, we just want to be sure that we don't actually throw gas on the fire. So urate-lowering gout is long-term therapy. I mean, once we have defined that somebody actually has gout, therapy with urate-lowering medicines like allopurinol is a lifelong therapy. But if you can do it, it's usually, for a lot of people, it's just 1 tablet a day and you're done with it. You just forget about it, okay? It helps keep the system in balance, okay? Again, you know, don't give it during an acute attack. Most patients will develop recurrent symptoms or tophi if they discontinue their therapy. And again, non-adherence is probably the biggest thing I deal with, and so I try to teach my patients about it. The 2 most common used urate-lowering medicines on the market today is allopurinol and Febuxostat, or Uloric is the trade name for that one. Both great drugs. Allopurinol is a lot less expensive, and for most people, that's the drug of choice. Okay, but again, these medicines, they don't treat gout flares. All they do is lower the serum uric acid level, and how it does it is, I told you, proteins are broken down by enzymes down to a level of uric acid, and the kidneys get rid of it. What allopurinol and what Febuxostat do is they basically come in and block an enzyme right here. And so what happens is you make less uric acid. Okay, if you make less uric acid, you have less to get rid of. Okay, and the chemical that builds up here is a lot easier for the kidneys to get rid of, so it's very effective in lowering lowering their risk for gout attacks. So the dosage is 40 to 80 milligrams of Febuxostat a day. Again, the goal is to try to get it below 6 milligrams per deciliter. The one nice thing about this is that some people worry less about using this medicine in people that have mild to moderate kidney disease. But if you titrate the dose well and appropriately with allopurinol, you can get by with using that also in people with kidney disease. You just have to watch it a little bit more closely. Side effects, like with any medicines, you have to watch for things like elevated liver function tests, nausea, joint pain, rash, but generally well tolerated. There is a concern, what is the cardiovascular risk associated with that? People also believe that people with gout have an increased risk for heart attacks anyway. So we're in the process of completing a 5-year study looking at this right now, so I think we'll know in the next year or two what that's going to tell us. Here's the biggest thing for most people is that, a 30-day supply can cost you $160. Of course, it depends upon your insurance, but, whereas you can buy a month's worth of allopurinol for about $10. Okay. There's certain drugs you don't want to mix with Febuxostat or allopurinol. One is azathioprine. They just don't mix well with each other, and what happens in that situation is that these drugs prevent these drugs from getting torn down, and then these drugs are toxic to the bone marrow at really high doses, and so you really have to watch their blood counts and things like that. Pegloticase, a really interesting drug. This is a uricase. It's basically a man-made uric acid destroyer. It's really phenomenal. Those people with a really grotesque-looking tophi that I showed you on here, I mean, it just melts away. This guy right here had these tophi, and in less than 4 months, here's his hand now. And we've seen some remarkable, Dr. Churchill's actually treating a young man right now that has had horrible tophaceous gout, I mean, basically incapacitating. And he tells me that the tophi are just melting away. But it's unbelievably expensive. I mean, thousands and thousands and thousands of dollars. Okay. One of the problems with this is that it's a good one-time solution for those really extreme cases. The problem is, over time, what happens is that a majority of the patients develop antibodies to this, and so either they start getting infusion reactions because their body's fighting the drug, or the drug just becomes less effective. So it's a great one-time therapy, meaning to kind of unload the body of the uric acid. It's not a good long-term solution. Okay. So prophylaxis, again, when we're starting therapy, again, I will use things like the non-steroidals, the steroids, the colchicine, and then prophylaxis can typically be discontinued 6 months after the onset of definitive therapy, and then once the uric acid levels have been normalized, then that's usually my time. So sometimes I can even get rid of the uric acid, the prophylactic therapy sooner than 4 months if they're doing really well. We don't really know how long prophylactic therapy should be for patients with tophi, but generally I follow, my gut feeling has always been I just follow the same rules, usually about 6 months. I'll take them off prophylactic management. If they flare again, then I put them back on it, and I leave them on it for another 3 or 4 months, and I try to get them off of it again. Okay. But for a lot of people, I've had good success just going somewhere around 6 months and being done with it. Okay. We talked about the water pill-induced hyperuricemia. The take-home message that's really nice about that is that for most people that have elevated uric acid levels related to their water pill, for most people that doesn't lead to gout, which is nice. So the take-home message in that situation is that we don't treat elevated uric acid levels that aren't associated with actual gout flares with NMB, and they typically resolve. So from flare to control, Somebody comes in with a flare, and again, my situation, this is what I normally do, kind of generically. Again, my situation is a little bit different because remember, I'm usually not treating somebody with their very first flare. I'm treating somebody with their 7th or 8th flare, okay? And so they've already had a lot of different therapies, and so I'm dealing with usually a more severe group of people that have had a lot of flares, and so oftentimes I will calm them down quickly with a 15-day cycle of prednisone. Some people will use what they call a Medrol dose pack, which is a 6-day pack. 6 one day, 5 one day, 4 one day. And the problem is the steroid burst is too short. They get down to 6 days. That 7th day, they flare again. Okay? So that's why I use a 15-day burst. I want to get them through the flare and get them quiet before I start something else. But I'll use prednisone. Sometimes I'll use naproxen or colchicine, depending upon what I need. A couple of weeks later, I kind of reassess their lab because I'd like to know, again, that 2 weeks post-flare, has a uric acid level actually gone back up so I can see what it is, okay? And then what I'll do is I'll start allopurinol. Again, it's safe, it's been around a long time. I start with 100 milligrams a day for a week, 200 milligrams a day for a week, 300 milligrams a day for a week. So people say, well, why do you do that? Again, as we talked about the balance of the system, okay, I don't want to use 300 and do this. I want to use 100 and do that and allow the body to adjust, and then 200 and adjust, and 300 and adjust, okay? Rather than just going like that and then causing more flares, okay? And then ultimately, my dose of choice depends upon what their serum uric acid level does. My goal is to get them under 6.0 milligrams per deciliter. So your allopurinol is approved for the use of anywhere between 300 and 800 milligrams a day, okay? A lot of people are on 300, but I have people on 400 or 500 depending on what they need to control their particular gout. And again, I may put them on a prophylaxis to keep their flares under control while we're getting the allopurinol on board. Okay, usually about month 3 or so, we're adjusting their allopurinol dosage. Okay, trying to get to that magic level. Okay, I'll probably decrease the colchicine as the uric acid level is coming down. I'll decrease the amount of prophylaxis that I need. By month 6, we continue to adjust the allopurinol dose. I stop the colchicine. I see them back usually 3 months later if we need to. And usually by month 12, their gout's controlled, they're on stable therapy, and I fire myself. Okay? And so that's usually